Hello, my name is John Ramage. I'm a professor of medicine and I work at the King's Health Partners Neuroendocrine Cancer, which includes King's and Guy's, Kent and North Hampshire Hospitals Neuroendocrine Centre. I think I know many of you well, and I hope that you're remaining free of news in this terrible COVID crisis that we're faced with. So I've been asked to give you a talk about neuroendocrine cancer terminology and classification and what that means for your care. I was slightly nervous about this topic because terminology and classification is not exactly the best topic for enthusiasm and for keeping people awake, but we'll see how we get on. So the first thing to say is that with all this terminology that's been used for the last 20 years around NET, it's all been thrown apart by the WHO classification recently, which has decided that the group as a whole is now called NEN and not NET. So the totality of what we're talking about is really neuroendocrine neoplasms, or NEN. Rather than neuroendocrine tumors. I know this is very confusing because we've got UK NETs and ENETs and Net Cancer UK, and are we going to change them all to UK NEN and ENEN? So we've got a bit of a dilemma there, but really the totality is really NEN or NEN. So within NEN, we've now got really two types of tumor. One is called the neuroendocrine tumor, and the other is called the neuroendocrine carcinoma, which you can see in this slide. And one of the important things to say is that the WHO have now termed all these tumors as malignant, which wasn't the case before. So they've decided that none of them are completely benign. And you may say that's a bad thing, but in some ways it may be helpful because the collection of the data worldwide is dependent on them being considered malignant. And what we had before was that the benign end of the spectrum were not being collected. And so now we will actually collect all the data on NENs, both NET and NEC. So if you remember, NEN is the totality, and then within that we have NET and NEC. And the NEC ones are a bit more malignant than the NET ones. So we can classify NENs in many ways. And this is where it's become quite confusing, but we can classify them by the site of the primary, since obviously a NEN of the small bowel is different to a NEN of the lung, for instance. So there's a classification there in terms of the actual primary. And most cases we can find a primary, although there are a few cases where it's been very difficult and sometimes impossible to find a primary. We can classify them by grade. And if you remember, grade is really a classification designed by pathologists when they're looking at the cells under a microscope. So the grade is how malignant the cells are. And they have lots of special tests that they can do on the slides to determine that. The third way of classifying them is by stage, and that's really how far the disease has spread, usually at the time of diagnosis. So we talk about stage 1 to 4, 1, 2, 3, and 4, and you will hear that mentioned in your notes, and it's maybe a good idea to have that information on your app or in your notes somewhere, so you can communicate that to other healthcare professionals. And the fourth, of course, is by the hormones secreted, such as insulin for insulinomas, or 5-HT for carcinoids. So the hormones secreted used to be considered the most important way of classifying the NENs, but nowadays it seems slightly less important, but there are some reasons why classifying by hormone may be important. I'm just going to go through the sites of primary, which may seem obvious, but there are some quirks in the terminology. So if we look at neuroendocrine neoplasms, or NEN, which is the whole, the totality, we have pancreatic endocrine tumors, which can also be called PANNETs or PNETs or PNENs. So there's lots of different names for them. It's very confusing, but they originate in the pancreas, which is the organ just sort of behind the stomach, behind the duodenum. We get them in the stomach, which is gastro. We get them in the duodenum, which is obviously duodenal. We also get this hereditary condition called MEN1, which tends to include duodenal and pancreatic tumors. And moving on, one of the most common forms of NEN are appendix. So it says appendix net there, but officially they're appendix NENs. That's a very common finding, especially in young people. So we often get teenagers that have an appendix removed, and they have an appendix net or a carcinoid within them. So that's a common finding. And then there's a funny thing called goblet cell, which used to be a neuroendocrine tumor, but in fact has now moved out. So it's in black because it's really no longer officially part of our neuroendocrine neoplasms, although we do get referred quite a lot for commenting on. It's officially a slightly different kind of cancer, so probably in the future it won't be part of NENs. And then the small bowel neuroendocrine tumors, which we see a lot of, and they tend to spread before they're diagnosed, and there are particular ways of treating these that are very important. And then we get them in the colon, which is large bowel. And as part of bowel cancer, which I'm sure you're all aware of, is a very common cancer, there are some bowel cancers that have what's called neuroendocrine differentiation, which means that there are some neuroendocrine cells within the bowel cancer. And that's called a MANEC or MANEN. And then there are lung neuroendocrine tumors, which are very important and quite common. Commonly, they're small and relatively benign and can be removed without any spread, but there are ones that are more aggressive. And then there are adrenal tumors, which are sort of on the borderline of neuroendocrine tumors. In our hospital, we have a separate team that looks after adrenal tumors. So they can be considered part of neuroendocrine, but can be on the periphery and can be dealt with by slightly different teams. And they tend to secrete adrenaline and other hormones, which are not quite the same as what we deal with. And then there's medullary thyroid cancer, MTC. So this is a particular kind of thyroid cancer that is neuroendocrine. And lastly, there's a thing called Merkel cell carcinoma, which is a neuroendocrine tumor of the skin, which is quite rare, but we do see quite a lot of those. So this is really the family of NENs divided up into primary sites. Now I'm going to talk about grading, which, as you can see, is designed by pathologists who sit in their offices looking at tissue down microscopes and grading these tumors. And the pathology is incredibly important, partly because the grade of the tumor is one of the things that most affects what happens to the tumor in the future and how aggressive it is. So as you can see here, we have essentially 3 grades, G1, G2, and G3. So you'll see them discussed as G1, G2, or grade 1, grade 2. And the next column there is mitotic count, that's the number of cells that are dividing and turning over. And the more mitoses you have, the more aggressive the tumor cells are likely to be. And there's a thing called Ki-67 index, which you may well hear about, related to your tumor. And as you can see, that the Ki-67 index is essentially a stain put onto the tissue and looked at under a microscope. And the split into less than 2% and 3 to 20% determines which grade they're in. And then lastly, the last column there, there's a cell type which is well differentiated and poorly differentiated. I'll try and illustrate that in one of the subsequent slides. And as you can see on the left column, the first two groups by and large are considered NETs, NETs, which are more benign. And the final one is NEC, or neuroendocrine carcinoma, which is usually termed G3, and that is a NEC. Although the slight googly in this is the new classification suggests there may be an intermediate group, otherwise known as G3 NET, which is sort of between grade 2 and grade 3. So nothing is as simple as it was originally thought. So there may be at least one more row in the future in that slide. So I apologize for showing you pathology slides. I've only got one pathology slide. I don't know if you can see in the top left the sort of purple, looks like a modern art picture. I don't know if you can appreciate palisading. If for those people that are gardeners, you can imagine that palisading is essentially a sort of fence with regular things sort of stuck together in a line. I don't know if you can appreciate that there are, in that slide, there are regular cells stuck together in a line or palisade, and that indicates a well-differentiated tumor. And on the bottom right is the Ki-67 stain, and it's the brown bits, the brown cells there, that we're looking at. And this is an example of very low Ki-67, and what we're looking at is the ratio. The percentage is really the ratio between the brown cells and the light blue cells. And as you can see, there's much more blue cells there than there are brown cells, and so the percentage of this one is very low. So pathologists have ways of working this out to form a percentage of the Ki-67. So this one's very low, and generally that does indicate a better prognosis. So I was going to move on to a stage of stages of NENs. So as you can see here, there are 4 stages. So stage 1 is often someone that has a small appendix net, like less than a centimeter, or a small lung net less than a centimeter, and those are removed at surgery, and there's not going to be any further recurrence of that tumor, and often those patients can be reassured that there's going to be no recurrence, and a lot of them won't need any follow-up either. Stage 2 is the tumor that has invaded slightly more into the organ that it's found in. So it often can be removed at surgery, but there's possible recurrence, and so the patient needs to be followed up. And stage 3 is where the spread to lymph nodes. So lymph nodes are like glands you get in your neck when you have a sore throat. So lymph nodes occur all over the body, and if you get spread from the tumors, then you get spread into regional lymph nodes, and that's a stage 3 tumor. And the stage 4 tumor is where it's spread to other parts of the body. So if you have disease within the liver or lungs or bones, then that's obviously stage 4 disease. And I think a lot of people in the neuroendocrine community actually unfortunately have stage 4 disease because they need to be seen regularly, and a lot of the stage 1 disease people will just try and forget about it and won't be part of the community. You might also have heard of a thing called TNM, which stands for Tumor Nodes Metastases Classification, and this again is part of staging. So what happens is that we define the TNM, the tumor nodes and metastases, and there's a sort of matrix where that combines into the stage. So this is the early part of forming the stage. And so this often happens in the multidisciplinary meeting, or MDM, that you may have heard about. So we have pathologists present in the MDM, and they tell us how big the tumor is, and they tell us how far it's invaded, for instance, within the muscle wall of the bowel. So that can be anything from T1, 2, 3, or 4. So you'll often hear us talk about T3 tumor, and that may well be in the summary of your notes. And the next one is the N, which is lymph nodes, and everyone has lymph nodes, so you can have small lymph nodes throughout your body which are normal, but the pathologists need to sample the lymph nodes if possible, usually from a surgical specimen, and decide, do they have tumor cells within them? So if there are tumor cells present within the nodes, that becomes an N1 tumor instead of N0. So N0 is no tumor cells, N1 is tumor cells within the lymph nodes. And then there's M for metastases. So this is obviously, is there any disease elsewhere? So it's a disease within the liver. So this is often determined more by radiology than pathology. And you can be M0 or M1. So often at the top of the notes of someone that's had an operation, you'll see something like T2, N1, M0. And that translates into a stage, and that's important because it gives us a prognosis, and it gives us an idea of how the patient should be followed up. So I'm sorry to put you off your lunch or dinner or whatever time this is being shown. This is just to show a specimen that's been removed from the bowel. So this is an example of a stage 1 net. So I don't know if this has been removed at endoscopy. So on the bottom left, the white bit is a very small tumor, and the blue surround is essentially fluid that's been injected to lift it away from the muscle. And then in the bottom center, you can see the scar where it's been removed. And then the top right, you can see this tumor that's actually been removed and is now on a piece of cork outside the body, and that's to be sent off to the pathologist who can section it. So this is an example of a stage 1 net, which is small, has not invaded the muscle layer, has had no spread, has been removed at endoscopy, and it's likely that this patient will be cured. So that's a stage 1 net or NEN that's been cured. And moving on to the other end of the spectrum, which is stage 4. So if you look at the top arrow, which is the small bowel primary, I don't know if you can see, but there's a small sort of whitish or light gray round thing at the tip of that arrow, which is actually the primary tumor that had invaded the muscle layer, and so it was a T4 tumor. I don't know if you can see with the middle arrow that points to nodes. So this is an N1 disease, and there's an area where at the tip of the arrow, which looks a bit like a little lump with sort of crab-like extensions or star-like extensions coming out from it. This is a mass of nodes, so this is N1. And the bottom arrow, or leading into the liver at top left, these point to those little dark areas in the liver, which are metastases. So this was M1 disease. So put the T4N1 and M1 together, and you put it into this matrix, and that would come up with stage 4 disease. So this is an example of stage 4. So you may well find the stage on your notes. So why are we doing this? So why is the stage important? Well, I'm sorry that this slide is a bit complicated, but I show this because it's data from England and Scotland and Wales. So this is 1 year survival. So the actual survival overall, for instance, for carcinoid tumor, which is the green line there, you can see that along the bottom, these are stages 1, 2, 3, and 4, and I think you can see that this 1 year survival for stage 4 is somewhat lower than the 1 year survival for stage 1, which is as you might expect, because if you have very extensive disease and it spread, your average survival might be slightly lower than stage 1 disease, I'm afraid. I mean, it's not very low, but it's slightly lower at 1 year than stage 1. So not all patients will want to know what their survival is, but some people are very insistent. They would like to know the exact average survival of their disease, and you can only really give someone an average survival if you know the stage and grade. And this is an example of showing why stage is important in determining the likely survival and prognosis. So we can classify the tumors by hormones secreted as well. So at the top we have carcinoid tumors. So they secrete this thing called 5-HT or serotonin. So in small doses, serotonin is supposed to be the happy hormone, but when it gets into very large amounts in the body, it causes severe flushing and diarrhea, and it can make people feel extremely unwell. That has effects on other organs in the body, including the heart. So we see a lot of people with carcinoid syndrome, and they particularly occur with small bowel tumors and people with liver metastases. And it's important to recognize this because the octreotide and lanreotide, or sandostatin and Ortogel, as you know, you may be having, do have an effect in controlling this. So it's important to know the levels of 5-HT in the blood or urine and how they're being controlled. And it's particularly important to try and protect the heart if there are very high levels. And that's why we'd use somatostatin analogs, octreotide or lanreotide, to control that. And for instance, the second one might be gastrin secretion. So gastrin is a hormone that increases stomach acid and can cause diarrhea. So sometimes people present with stomach ulcers and they get diarrhea, partly because of the secretion of acid that goes into the gut and causes a diarrhea. And the treatment of that is very high dose omeprazole, which is a drug that reduces stomach acid, and you can also use octreotide. So it's important from the treatment to know which hormone is being secreted by these tumors. And thirdly, insulin, which is obviously known as an insulinoma, which tend to occur in the pancreas. So they tend to cause low blood sugar, and when you're very hungry and haven't eaten for a long time, you feel slightly sweaty and faint. And if it's very bad, people can have fitting with this. And that's treated by other drugs such as diazoxide and can again be treated with octreotide. So there are lots of different treatments for these, but there are some that are specific to the particular hormone. And there are lots of different hormones, so I haven't got time ready to go through all the hormones, but there are much rarer symptoms such as PTH, which gives you a high calcium, VIP, which gives you terrible diarrhea, somatostatin, which can make you put on weight and give you gallstones, glucagon, which puts your sugars up, and ACTH, which makes you put on weight and gives you a thing called Cushing syndrome. So there are lots of different hormones, and some of them have specific treatments. So it's useful to know what hormones are being secreted. So again, why is classification important? Well, firstly, to determine prognosis. As we've seen, we need to classify the tumor in terms of grade and stage, site of primary, and hormones to give some idea of prognosis. And I think increasingly people are wanting to know their likely prognosis, although averages are obviously tricky to apply to the individual. We need to know it because we need to apply certain treatments. So surgery obviously is going to be more effective in an early stage. If it's a single small tumor, then it's certainly likely it could be removed with no recurrence. So that's another reason why it's important. The hormone secretion, as we discussed, it's useful to know that because we might need to adjust the dose of octreotide or lanreotide to control the hormone secretion. And then we need to know the grade because, as you know, chemotherapy is used in a certain section of tumors, and it's much more useful in high-grade tumors. So that's one of the reasons why it's important for us to know the grade of the tumor. And this can only be obtained at surgery or biopsy. And I guess the other thing to say is that, grade can change because some of our patients see us over 5 or 10 years, and the grade can change over a number of years. So some people may need a repeat biopsy. And the other reason that we need classification is that we need to make decisions on follow-up. For instance, stage 1 disease, so tiny tumors of the lung or appendix, they may not need follow-up at all post-surgery. So we don't want to put people into this process of having CT scans every 6 months, particularly for young patients, because it just causes a lot of anxiety. And if we're sure that it's not going to recur, it's much better to tell the patient, you don't need more scans. You don't need to be followed up long term. So stage 2 or 3 disease is more difficult and may need follow-up depending on the grade. And stage 4 disease will virtually always need follow-up, I'm afraid. So in summary, classification of NENs is not a very interesting topic, but it is necessary. It's necessary for giving predictions for the future. It's necessary for deciding on treatments, and it's necessary for deciding on the length of follow-up. So it might be dull, but that's why we do it. So remember, overall, the take-home messages are: what's the site of the primary? What's the grade of tumor? What's the stage of tumor? And what's the hormone secreted? So these are all important factors that we should bear in mind for all patients. So thank you for listening. That's my name and affiliation there. And keep safe, and all the best for the future.